So Andy, we've talked about the diagnosis, and of course with any patient who has newly diagnosed disease, there has to be a treatment plan. So you obviously were not a surgical candidate because you had disease that was outside the prostate, likely metastatic to the bones and or lymph nodes. So, did you consider yourself a partner in your own care when this whole scenario unfolded? Because people are telling you, well, you probably should do this, and other ones telling you do that. And obviously you need a pathway to choose. And so some people feel somewhat, I would use the word cautioningly, which is impotent in terms of, how do you,
I would say daunting.
Daunting.
It
I
could
say
be
impotent,
daunting
but
to
the
the
question
consumer
is, how do you proceed? Were you involved, essentially, or did somebody say, well, this is what you have to do, and that's it?
No, the way that it was set up for us is that we were presented with appointments to 3 different specialty areas. So I was set up, we didn't have confirmation of the metastasis at the time. So I was set up with a surgeon just to discuss the surgical possibilities. I was set up with your office to visit with you. And then I was set up with radiology. And in the radiology discussion, we talked about the confirmation of whether there was something, let's really be sure about the metastasis. And so in this part of the surgical workup, the PET scans and the other scans came back, and absolutely. So at that point, surgery then dropped out of the equation. And then at that point, we followed your lead. So the lead of working with you and looking at radiology, the approach that you explained about dealing with ADT made the most sense. And so we embarked on that. And as I remember, you started me on Degaralex, or how about I get the pronunciation right, and to reduce the testosterone, and then moved me to the Lupron. But the thing is, it was very much still this team approach, which is, radiology being involved in the PET scans and working with you, and surgeries available if it's necessary. The part that I took was basically trying to remake myself so that I could accept also the future treatments that were coming my way, because I was frankly in terrible shape. And so that's when I started embarking on exercise and diet and try and turn my own body around, because I knew that there was going to be a lot of work to do.
So essentially, you were really more than a partner in your own care. You were actually a leader in your own care, because as physicians, we all can tell patients what to do, but not everybody necessarily wants to engage. And I think one of the main issues for our audience to understand is that many years ago, if you had metastatic disease to bone or lymph nodes at the time of diagnosis, you were pretty much on hormonal therapy for the rest of your lives. And the novelty now is that we have 3 approaches for people with metastatic disease. One is a straight up hormonal manipulation, which is standard for many a person. We could give a combination of a drug, abiraterone and prednisone, along with androgen deprivation therapy, which is also a standard of care based on a number of New England Journal of Medicine trials. And then thirdly, we could give chemotherapy, and we talked about the role of docetaxel along with androgen deprivation therapy, but one has to keep in mind, chemotherapy is not for everyone. You didn't have a particularly high tumor burden, which is why we elected to go with the Zytiga, prednisone, and the androgen deprivation therapy.